The management of rectal cancer is currently splitting into two distinct pathways. For tumors in the lower rectum, protocols increasingly demand intense neoadjuvant therapy, a combination of chemotherapy and radiation administered before surgery. Conversely, patients with upper rectal tumors are increasingly skipping radiation and proceeding straight to surgical resection. Deciding which pathway a patient takes relies entirely on accurately locating the tumor. Historically, clinicians did this using rigid, fixed measurements, classifying any tumor within 15 centimeters of the anal verge as a rectal cancer. This is a sagittal MRI showing conflicting rectal boundaries based on differing measurement criteria. The measurement approach ignores natural human variability. Because the length of the anal canal and rectum varies significantly depending on a patient's gender and body habitus, a tumor sitting 13 centimeters from the verge might be classified as an upper rectal tumor in a tall male patient, but as a sigmoid colon cancer in a shorter female patient. Relying on a fixed ruler risks severe overtreatment or undertreatment. To triage patients correctly, radiologists must map the rectum using a three-dimensional model built entirely on fixed, patient-specific anatomical landmarks. This comparison shows the anatomical anal canal on the left and the surgical canal on the right. The anatomical canal ends at the dentate line. The surgical canal, however, is a functional unit defined by the sphincter complex, extending into the lower rectum. Looking at this coronal MRI, we pinpoint the true inferior boundary of the rectum. It is not an arbitrary 0 to 5 centimeter mark. It is the top of the puborectalis sling, the thickened muscle on either side, which forms a horizontal plane known as the anorectal ring. Establishing this boundary dictates the surgical approach. If a low rectal tumor extends downward, involving the levator ani muscles or external sphincter, standard resection is impossible. The surgeon must perform an extralevator abdominoperineal resection, completely removing the sphincter complex with the rectum. This exact involvement also dictates pathological staging. Under guidelines from the College of American Pathologists, tumor invasion into the levator or external sphincter structures immediately upstages the disease to T4B. Identifying the anorectal ring on an MRI dictates whether a patient preserves or permanently loses their natural sphincter function. Moving superiorly from the pelvic floor, we reach the most critical oncologic divider in the pelvis, the anterior peritoneal reflection, or APR. On this axial MRI, the APR appears as this distinct seagull configuration. This is the exact point where the visceral peritoneum, the membrane enveloping the abdominal organs, reflects off the bladder and seminal vesicles, or uterus, and attaches onto the anterior rectal wall. The APR strictly subdivides the rectum into two distinct zones. Below the reflection is the extraperitoneal lower rectum, sitting outside the peritoneal cavity. Above it is the intraperitoneal upper rectum, which is suspended inside the cavity. This map shows the zones separated by the APR. The extraperitoneal lower rectum drains laterally into the lateral pelvic lymph nodes, creating a severe recurrence risk. Conversely, the upper rectum drains superiorly. Sitting higher in the wider pelvic basin drastically lowers its local recurrence risk. The APR serves as the ultimate systemic watershed. Tumors located below the reflection generally require total neoadjuvant therapy to address the lateral recurrence risk, while stage 2 and 3 tumors above the reflection can often proceed directly to surgery. To cap the upper limit of the rectum, we must discard historical landmarks. For decades, clinicians used the sacral promontory, the inward projecting top edge of the first sacral vertebra. However, this bony landmark does not accurately reflect the soft tissue transitions. This sagittal MRI highlights the sigmoid takeoff, or STO. This is the exact point where the rectum pulls away from the sacrum and flexes anteriorly. It marks the transition where the fixed mesorectum ends and the highly mobile sigmoid mesocolon begins. This physical flexion point precisely correlates with a vascular divergence. It is the exact location where the superior rectal arteries separate from the sigmoid arteries. Locating the STO locks in the definitive sealing of the rectum. By correctly categorizing high tumors as either upper rectal or sigmoid, it protects patients from undergoing aggressive, unnecessary rectal radiation protocols. With the vertical borders established, we must map the horizontal envelope surrounding the tumor. This requires addressing a widespread error, conflating the anatomical mesorectal fascia with the circumferential resection margin. Panning through these cross-sections, watch the outer boundaries. The mesorectal fascia is the fixed membrane surrounding the lower rectum. Above the APR, the peritoneum gradually envelops the anterior rectum, and the MRF diminishes until disappearing at the sigmoid takeoff. This schematic compares the static MRF to the CRM. The CRM is not an anatomical structure, it is the potential surgical dissection plane. While standard surgery follows the MRF, the CRM must deviate outward if a low tumor involves the sphincter muscles. This scan demonstrates the criteria for MRF involvement. We look for a tumor breaching the muscular wall at its base or extramural vascular invasion into blood vessels. If these primary extensions sit within 1 millimeter of the fascia, the MRF is involved. Here, a heterogeneous spiculated nodule, a jagged tumor deposit, sits less than a millimeter from the boundary, constituting MRF involvement. However, a smooth, completely encapsulated mesorectal lymph node, even if malignant, does not constitute MRF involvement. Radiologists must report on the immutable anatomical reality of the MRF. They should not attempt to guess the surgeon's dynamic CRM. The operative team requires the absolute anatomical truth before making their first cut. Revisiting our initial sagittal view, we can assemble the completed architecture: the anorectal ring at the floor, the anterior peritoneal reflection in the mid-pelvis, and the sigmoid takeoff at the ceiling. Each specific coordinate dictates a massive clinical decision. The ring determines sphincter preservation. The reflection determines the necessity of total neoadjuvant therapy. The takeoff determines whether the disease is treated as rectal or sigmoid cancer. By abandoning rigid measurement rules in favor of precision MRI landmarking, the clinical ambiguity of the past is removed. Radiologists provide a definitive staging roadmap, minimizing local recurrence risk and directly improving patient survival.